5 centuries ago, the Swiss physician Paracelsus established the foundational rule of toxicology: the dose makes the poison. That rule still governs deliberate poisonings today, where extremely potent and obscure agents are weaponized, like the use of pure TCDD or dioxin against Ukrainian presidential candidate Viktor Yushchenko. And when that threat shifts to mass public exposure, like the 1982 Chicago Tylenol tampering cases, it forces entire industries to redesign how over-the-counter pharmaceuticals are packaged and sold. But when the crash doors open today, emergency teams aren't dealing with industrial policy or forensics. They have a critically unstable patient crashing from an undifferentiated exposure, and time is running out. This forces a difficult clinical reality. The medical team must reverse cellular damage they cannot name, because while the patient is dying in the present, laboratory confirmation is often hours away. For decades, the immediate medical reflex was to attack the poison itself. Doctors routinely attempted aggressive physical extractions, like immediate gastric lavage, hoping to pump the threat out before it absorbed. Modern practice removes that step. It relies on a strict heuristic that ignores the search for a specific chemical name in favor of immediate stabilization of the patient's vital signs. This algorithm operates in 3 distinct phases: empiric resuscitation, physical toxidrome recognition, and targeted toxicokinetics. In critical poisoning, survival is determined by how well the team defends the body's systems, regardless of what's attacking them. Because the poisoned patient is often unconscious, and bystander history is notoriously unreliable, the algorithm demands immediate empiric therapy based purely on the patient's physiology. If the physical exam reveals a respiratory rate at or below 12 breaths per minute, that single metric mandates the immediate administration of naloxone to reverse potential opioid-induced apnea. Once initial stability is achieved, junior clinicians consistently make the same diagnostic error. They order a standard urine drug screen. These immunoassays are limited in emergency resuscitation. They provide qualitative results with no quantitative data. They tell you a substance is present, but they cannot tell you if the concentration is actually causing the symptoms, and they completely ignore the patient's pharmacological tolerance. This diagram shows core physical toxidrome assessment zones. Instead of waiting hours for lab assays, assessing eyes, lungs, and bowel sounds provides immediate data. Pinpoint pupils, profuse sweating, and hyperactive bowel sounds instantly map to cholinergic receptor failure, broadcast in real time. A targeted physical evaluation provides the speed necessary to guide critical interventions long before a qualitative assay returns from the lab. To look deeper into the patient's status, clinicians use the electrocardiogram as a real-time monitor for cellular ion flux. This chart relates cellular electrolyte movement to the ECG. Focus on phase 0. Rapid sodium influx creates the sharp QRS spike. When poisons block these sodium channels, they slow ventricular depolarization, visibly widening the entire QRS complex. This delay physically alters the direction of the heart's electrical vector. It creates a pronounced rightward axis shift, a predictable consequence of tricyclic antidepressant toxicity. To find this blockade, you do not look at the entire rhythm strip. You isolate the terminal 40 milliseconds of the QRS complex. This specific segment is read in a single location on the 12-lead, lead AVR. This ECG shows severe TCA poisoning. In lead AVR, observe the prominent upward terminal deflection at the end of the QRS complex. When the absolute height of that terminal R wave exceeds 3 millimeters, clinical risk escalates rapidly. This specific morphology predicts impending malignant dysrhythmias and seizures. It allows the team to see the failure of cardiac ion channels before blood levels result. Mastering the toxic ACG allows clinicians to detect and preempt catastrophic electrical collapse by reading the body's cellular status in real time. With the airway secured and ion channels monitored, the heuristic progresses to its final node, preventing further systemic absorption through gastrointestinal decontamination. Single-dose activated charcoal is the primary tool. Its massive internal surface area actively binds and physically traps stomach poisons before they enter the bloodstream. This intervention carries a strict prerequisite. Activated charcoal requires intact airway reflexes or an endotracheal tube, because pulmonary aspiration of the thick charcoal liquid into the lungs can be fatal. For poisons that evade charcoal, clinicians deploy whole bowel irrigation, a highly aggressive secondary modality. This technique uses a polyethylene glycol lavage solution to create a continuous osmotic flush through the entire GI tract. This massive volume washes toxic material out before absorption, forcing 2 liters per hour through the patient. This measure is reserved for a specific pharmacokinetic profile, massive ingestions of sustained-release pharmaceuticals that continuously leak toxins into the gut over many hours. It is also used for radio-opaque heavy metals, like iron, which evade charcoal, or for clearing tightly wrapped packets of illicit drugs from body packers. Modern decontamination is never a reflexive protocol. It is a precise intervention used only when the toxicokinetics of the ingestion warrant it. These heuristic steps save lives daily, yet the academic foundation supporting them is surprisingly thin. This chart shows the AHA's evidence grading for critical toxicology. Notice the heavy reliance on level C categories, limited data, and expert opinion. Most resuscitation recommendations don't stem from randomized trials, relying instead on physiological rationale and expert consensus. And sometimes, despite perfect execution of the algorithm, the heart fails completely, entering refractory cardiogenic shock. When hemodynamics fail, teams deploy VA ECMO. This ECMO circuit acts as a mechanical bridge. It artificially sustains oxygenation and blood pressure, keeping the organs alive just long enough for the body's own systems to filter the poison out. Waiting for absolute laboratory confirmation in the setting of critical toxicology is a lethal error. In the resuscitation bay, the stakes are absolute, and the margins for error are measured in seconds. Managing these cases requires a rigorous, unyielding defense of human physiology, proving that in the resuscitation bay, the most effective tool against an unknown toxin is an expert understanding of the living body.